Emergency episiotomy. An emergency episiotomy is a cut made in a woman's perineum to make her vaginal opening larger right before the birth of a baby. It can help to speed the birth for a baby in distress. It is not a routine procedure. It increases the woman's risk of more severe tears, too much bleeding, infection, and painful healing. This video will cover when an emergency episiotomy may be necessary and how to do one safely. Episiotomies are rarely needed and should never be routine. An episiotomy may be needed if there is true fetal distress and sometimes for a vacuum or forceps birth. In this example, the woman has been pushing for a long time. The baby's heart rate is dropping, and he has a large caput. The midwife has decided an emergency episiotomy is needed to get the baby out quickly. Many birth attendants believe episiotomies are beneficial for women giving birth for the first time. They think the perineum will be too tight to give birth without a large tear. This is a mistaken belief. The perineum will stretch. Skillful support as the head emerges will help minimize or even prevent tears. Keep in mind that an episiotomy is often more damaging than a natural tear would have been. An episiotomy cut can extend even longer and deeper during the birth process. Episiotomies are very painful and take longer to heal than natural tears. The cut can also become infected or cause heavy bleeding. There are 3 ways to cut an episiotomy. A midline cut goes straight down from the vagina toward the anus. Midline incisions often have less blood loss, less pain, and heal best, but they risk tearing into the anus. A mediolateral cut usually starts at the bottom center of the vagina and points toward one side or the other. These cuts are less likely to tear into the anus, but can be more painful, bloody, and often cut into muscle. A lateral cut starts off-center and points to one side or the other. This cut may have even more muscle damage, pain, and scarring. If you decide an emergency episiotomy is needed, let the woman know that you have to perform an emergency procedure and get her consent. Also, ask her if she has an allergy to local anesthetic. You will need sharp, sterile scissors with a rounded blade on one side, plus a 10 milliliter syringe filled with a local anesthetic, such as lidocaine. Wait until the vagina is bulging open, the perineum is thinned out, and you can see 3 to 4 centimeters of the baby's head or bottom pushing out during a contraction. You should expect that the presenting part will emerge during the next few contractions. Cleanse the perineum. Then give the local anesthetic. Place your 2 fingers between the baby's head and the perineum to protect the baby. Then insert the needle beneath the skin to the depth of the needle along the line your cut will follow. Draw back on the plunger to be sure the needle is not in a blood vessel. Then inject the medicine as you slowly withdraw the needle. Try to wait a few minutes for the anesthetic to work. To cut the episiotomy, again, place your 2 fingers in the vagina to hold the skin away from the baby. Open the scissors and put the rounded blade inside the vagina, keeping the blades of the scissors at right angles to the surface of the skin. With a firm grip, make a small snip in the perineum. Sometimes, just releasing the tension with a small cut is all that is needed. In between contractions, press on the cut with a sterile cloth to slow the bleeding. Control the birth of the head and shoulders to avoid extending the cut. After the birth, carefully examine the genital area and sew the cut tissue together. Remember, an episiotomy should never be routine. One of the only indications is true fetal distress. Wait to cut until the presenting part is almost ready to emerge to reduce bleeding.